please type on the Q&A box. We are going to choose some of them to be answered live in the end of the session. And if you want to make your own question live to Dr. Anderson, please click on raise your hands. And in the end of the meeting, we are going to welcome you as a panelist, so you're going to be able to make your question live. We want to invite you to join us on Monday, 17th of August, in our first cardiac intensive care practices in 2020. We are going to talk about data or dogma. It's going to be very nice in a different setup. It's going to be very, it's going to be a case-based presentation, and we're going to have a panel for discussion. It's going to be very interactive, so we hope all of you can join. Don't forget that in September, we are going to continue with Dr. Silverman imaging series. This has been very nice. And last week, he talked about, in the beginning of this week, he talked about transposition, the correlation of pathology and echo. And we want to welcome Dr. Anderson once more to be with us today to talk about morphology of transposition. We are very happy to have you, Dr. Anderson. Once more, thank you very much. This has been very, very important to all of us to learn and on this way to treat better our patients. Thank you.
Oh, good afternoon to all of you and welcome from London. I'm sitting here at the moment at 38 degrees. Sasha tells me that in Sicily it is raining, which is not good news in Sicily. I'm not quite sure what the temperature is for Grace in Qatar, but I guess it's close to 38 degrees, 38 degrees, so we are in the same situation today. I confess that I did not watch what Norman had to say to you earlier in the week on transposition, but I do hope that what I am going to be telling you today will be paralleling what Norman told you earlier in the week. For those of you who watched the earlier session, I'm pretty sure it will be the same because he usually steals my images, and I doubt that it's going to be much more different from what we see today than what you saw earlier in the week. So, as is usually the case, Sasha recorded my presentation on Monday, or Tuesday rather. We were very happy with the outcome. So I'm now going to pass you back to Sasha, who will start our video. And then, as Grace has said, at the end of the video, I will be here to answer your questions, either directly in person or via Grace with the chat option. So please feel free to ask the questions. Well, good afternoon to you, ladies and gentlemen. The lesion we are going to be discussing this afternoon has often been the source of controversy. I'm showing you at the moment the first picture of the entity as far as we are aware. It's a drawing made by my countryman Matthew Bailey, and it was made at the end of the 18th century. And when Matthew Bailey was confronted by this lesion, he had no problems. He simply called it a singular anomaly. And nobody could argue with him at the time. Since then, however, as I have intimated, it has been the root of many disagreements. And these relate to the feature we choose to define the entity. Should we define it on the basis of the ventricular origin of the arterial trunks? Or do we always have to find an anterior aorta in order to define this entity? And if there is an anterior aorta, does that aorta have to be supported by an infundibulum or a conus? And does there have to be fibrous continuity between the leaflets, the pulmonary valve and the mitral valve in the left ventricle? Now, the problem in the past is that these features are mutually independent one of each other, as we will see as we progress through our discussions today. And yet for a long time, it was argued that all had to be present at the same time. And it was that insistence that they all be present for the larger part that has led to the many disagreements. So I think nowadays we all agree that there is no question which feature is most significant, and that is the ventricular origin of the arterial trunks, because it is the ventricular origin of the arterial trunks that determines the way the blood goes round. And to you as clinicians, surgeons, pediatric cardiologists, unequivocally, it is the direction of the blood that is most important. So what we are talking about is the arrangement which the aorta is supported by the morphologically right ventricle, and the pulmonary trunk arises from the morphologically left ventricle. But then we must also take account of the way in which the atrial chambers are joined to the ventricles. And that has also created problems over the years. Because if we go back and if we consider why we use this word transposition, which I'm going to tell you is now my favored term for the anomaly, transposition means no more than placed across. And so if we look back at the way nomenclature has evolved, at one time we found that transposition was considered to be complete when both the arterial trunks were placed across the septum. In other words, origin from inappropriate ventricles, which we've already said is the most important feature. But at that time, there was also description of partial transposition, in which only the aorta was placed across the septum so that it and the pulmonary trunk arose from the morphologically right ventricle. And nowadays, of course, we call this double outlet right ventricle. Now, when I started in this field, which is now a long time ago, it was often thought that complete transposition was a suitable term for the entity we're going to discuss today. But whenever we have discordant ventricular arterial connections, irrespective of the atrioventricular connections, both arterial trunks are always placed across the septum and hence are completely transposed. So what we have to do is think about the combinations. And when we take into account the influence of the atrioventricular connections, we know that probably most frequently we find the discordant ventricular arterial connections in combination with concordant atrioventricular connections. We can also, however, find transposition, as we will define it, when the atrioventricular connections are discordant, and we call that now congenitally corrected transposition. Oftentimes, we find discordant ventricular arterial connections in the setting of isomeric atrial appendages. And then it is the venoatrial connections which dominate the picture. And so that is subtly different from the lesion we're going to discuss today, even when the venous return is quasi-normal. We can also have discordant ventricular arterial connections with double inlet ventricle. And indeed, when we have double inlet left ventricle, it is the rule to find discordant ventricular arterial connections. And we'll discuss this in a future classroom when we talk about the functionally univentricular heart. And there's another functionally univentricular heart in which one of the atrioventricular connections is absent. This, of course, on the right side is classical tricuspid atresia. And we can also find that with transposition, although typically in the setting of tricuspid atresia, the ventricular arterial connections are concordant. And we'll also discuss that when we move on to look at functionally univentricular hearts. But what we are going to discuss today is what I believe should now be the default option, which is discordant ventricular arterial connections combined with concordant atrioventricular connections. And I think we can simply call that transposition. We can even drop of the great arteries, because I'm unaware of anybody now who talks about transposition of the great veins. And when we find discordant ventricular arterial connections in the setting of those other atrioventricular connections, I think they are sufficiently unusual that we should take our time and we should give full description so that everybody knows what they're talking about. But when we talk about transposition in isolation, I come back to what I think is the default option, the combination of discordant ventricular arterial connections with concordant atrioventricular connections. So let's look at the setup we're discussing. Here you see the morphologically right atrium on the right side receiving the systemic venous return, and it is connected to the morphologically right ventricle, which is showing right-handed ventricular topology. And in this lesion, arising from the morphologically right ventricle, not the pulmonary trunk, as is usually the case, but the aorta. And this means, of course, that the blood is going to go around in parallel rather than in series, and that is the essence of this combination, concordant atrioventricular, discordant ventricular arterial connections, that I believe we can simply call transposition. So on the other side, pulmonary venous return coming to the left-sided, morphologically left atrium, goes into morphologically left ventricle on the left side, and then is pumped back to the lungs through the pulmonary trunk. But of course, this is only part of the picture. The greater majority of the patients you're going to see with transposition will have this setup, and it is the setup that is found with usual atrial arrangement. But on rare occasions, you can find this situation. Here, we have mirror-imaged arrangement. So the morphologically right atrium is now left-sided. It's joining into a morphologically right ventricle, which is also left-sided and now is showing left-handed ventricular topology. And it is giving rise to the aorta, which again returns the blood back in parallel rather than in series. So now pulmonary venous return is coming to the right-sided morphologically left atrium, which joins to the right-sided morphologically left ventricle, and then the pulmonary trunk pumps the blood back again to the lungs. Transposition with mirror-imaged arrangement. But for today, for the larger part, I'm going to be showing you the features of transposition as we see it here. There you see right-sided right atrium receives all the systemic venous return, although on occasion you can have anomalous systemic venous anomalies. The blood is coming through the morphologically tricuspid valve, and it is entering the morphologically right ventricle, which is showing right-handed ventricular topology. And then typically the blood is ejected from the morphologically right ventricle into the aorta, which is anterior and right-sided. And in almost all cases, the aortic valve is supported by a completely muscular infundibulum, or if you will, a conus. So if we look at the other side of the usual arrangement, the left atrium is left-sided. The blood is now coming through a morphologically mitral valve and is entering the left-sided morphologically left ventricle, and then is being pumped into the pulmonary trunk. And almost always, we find that there is fibrous continuity in the roof of the morphologically left ventricle, as we expect, between the atrioventricular valve and the arterial valve. But in the setting of transposition, of course, the arterial valve that is arising in the morphologically left ventricle is the pulmonary valve. So this is the typical arrangement of transposition, and here I am showing it you in the setting of an intact ventricular septum. And many times this will be called simple transposition. But there are, of course, many variable features. And it has been the presence of these variations that in the past has led to the disagreements in nomenclature. So in most instances, when we consider the arterial relationships, the aorta, as I've shown you already, is anterior to the right. But in some instances, the aorta can be directly anterior. We can also rarely, however, find situations in transposition, as I have defined it, concordant atrioventricular, discordant ventricular arterial connections, when the aorta is left-sided. And very rarely, with the same combination, we can find the situation where the aorta is posterior to the right. And that, of course, is so-called normal relations. And it was the finding of this arrangement that, when I started in the field, had created so much trouble in the definition. And we'll talk about that very shortly. But let me show you some of the examples in which the aorta is left-sided. Now, this is a picture that is taken in the operating room by my late lamented colleague, Benson Wilcox, with whom I worked together for very many years. Ben was the chief of cardiothoracic surgery in the University of North Carolina in Chapel Hill, and he took very many exquisite pictures in the operating room. And there's no question that in this particular patient, in which there was usual atrial arrangement, the atrioventricular connections were concordant, there was right-handed ventricular topology. Unequivocally, as you see here, the aorta arising from the anterior right-sided, morphologically right ventricle is to the left of the pulmonary trunk. We know it is the aorta because, as I've shown you with the arrow, it is giving rise to the right coronary artery. Now, as you also see, the right coronary artery is passing directly in front of the pulmonary trunk, and arising from the right coronary artery is the anterior interventricular artery, which is passing back across the subaortic infundibulum. So here, in the setting of usual atrial arrangement, with concordant atrioventricular connections, we have a left-sided, discordantly connected aorta. Now, if Richard van Praag was describing this entity, he would call it transposition SDL. And it is the presence of the transposition that tells you that the ventricular arterial connections are discordant. And then the segmental nomenclature gives you the rest of the picture. So no problems when we are using van Praagian nomenclature in this fashion. But here's another interesting part. Here you see the triangular atrial appendage, looking like the map of India upside down, is left-sided. And that, of course, is the morphologically right appendage. And the presence of a left-sided morphologically right appendage, a right-sided morphologically left appendage, tells us that we are dealing with mirror-imaged atrial arrangement. Again, the atrioventricular connections are concordant. So this time we have left-handed ventricular topology. And you see again here the anterior aorta arising in leftward position relative to the pulmonary trunk from the left-sided morphologically right ventricle. So here again, in van Praagian terminology, transposition tells us that we're dealing with discordant ventricular arterial connections. ILL tells us we have mirror-imaged atrial arrangement, left-handed ventricular topology. So putting this together, we should not be using detransposition to describe the entity that I am simply calling transposition, because in both of those instances, we had the combination of concordant atrioventricular connections, discordant ventricular arterial connections. The blood is going round in parallel. Neither had a D aorta. So we cannot use detransposition as a suitable name for the combination of connections we are talking about this afternoon. Now here is the other arrangement that created so much trouble in the early part of the 1970s. There is the aorta. It is positioned posteriorly and to the right. We have usual atrial arrangement. We have concordant atrioventricular connections. So again, the right ventricle is anterior and right-sided. And there you see the cut that shows you that in this heart, the aorta is arising from the right ventricle. It is discordantly connected. And there, to the other side, you see the cut showing you that the pulmonary trunk is arising from the left ventricle. We have discordant ventricular arterial connections. So here, the arterial trunks, in fact, are normally aligned. They are normally related, but they are discordantly connected. And this tells us that alignments are not always the same thing as connections. So when we are talking about connections, we are talking about the way the blood goes round. And so we must remember that rarely the aortic root can be normally related pulmonary trunk, spiraling arterial trunks, even when the ventricular arterial connections are discordant. But providing we define transposition as concordant atrioventricular, discordant ventricular arterial connections, we have no problem with description. So what about infundibular morphology? Well, we've already discussed the fact that usually we expect to find a subaortic infundibulum or conus and pulmonary to mitral fibrous continuity. But rarely we may find bilateral infundibulums or conuses. And in those cases where the aortic root is normally related despite the presence of transposition, usually there is fibrous continuity between the leaflets of the aortic and mitral valves in the roof of a ventricular septal defect. None of this matters as long as we define transposition on the basis of concordant atrioventricular, discordant ventricular arterial connections. So here I'm showing you one of those rare cases in which there are bilateral infundibulums. There is left ventricle. See, coming into the left ventricle, we have the morphologically mitral valve. Arising from the left ventricle, we have the pulmonary trunk. On the other side of the septum, the aorta was arising from the morphologically right ventricle. So the presence of this completely muscular infundibulum supporting the pulmonary trunk does not change the diagnosis. Concordant atrioventricular, discordant ventricular arterial connections, transposition with bilateral infundibulums. So those variations in relationships and in infundibular morphology do not change the basic diagnosis, and they do not change the definition. Much more important, in fact, particularly to you as clinicians, are the associated malformations, because they can change the hemodynamics. So we must expect on occasion to find a ventricular septal defect. We also know that of importance is obstruction within the left ventricular outflow tract. An atrial septal defect is often present as a naturally occurring entity, and oftentimes, even nowadays, still, you as clinicians will be creating an atrial septal defect by the Rashkin procedure. Oftentimes, the arterial duct remains patent. Also important, the major variations in the coronary arteries and other associated malformations. So we need to take account of all these variations when we are discussing the anatomy of transposition. So perhaps the most important complicating lesion is the ventricular septal defect. And what I now try to do is to use exactly the same system for categorizing ventricular septal defects in abnormal segmental combinations as when we have otherwise normal hearts, as we discussed just a few weeks ago when we presented the approach to ventricular septal defect. So here, in transposition, the majority of the defects are perimembranous. Oftentimes, however, as I will show you, with malalignment of the muscular outlet septum. As in the normal heart, muscular defects can exist anywhere within the septum. Rarely in transposition, we can find the situation in which the defects open beneath the airflow tracts and are doubly committed and juxta-arterial. So let's look at the details of these different types of communications between the ventricles. So here, in my experience, is the commonest defect. It's opening centrally at the base of the ventricular mass, and when we look at its posterior inferior border, we find that there is fibrous continuity between the leaflets of the tricuspid and mitral valves. And it is that feature, the presence of tricuspid to mitral valve continuity, that makes the defect perimembranous. And once we know that the defect is perimembranous, we also know that the conduction axis will be found related to its posterior inferior quadrant. And in most instances, in the setting of transposition, not only will there be tricuspid to mitral continuity, but also there will be continuity between the tricuspid and the pulmonary valves in the roof of the defect. But it is tricuspid to mitral continuity that is the phenotypic feature. Now here's one of the muscular defects that we might find in the setting of transposition, and what we particularly want to know is the relationship to the conduction axis. And we know the atrioventricular node will be found at the apex of the triangle cock. The right bundle branch will emerge beneath the medial papillary muscle. So when we put in the conduction axis here, we see that it is running in anterocephalad fashion relative to the ventricular septal defect. And in fact, the defect has exclusively muscular borders and is opening to the inlet of the right ventricle. It is a muscular inlet defect, and it is because it has muscular borders that we find the conduction axis running in anterocephalad fashion. So both geography and borders are of importance, but it is identification of the borders that give us the crucial information as to the location of the atrioventricular conduction axis. And we see that particularly well in this particular heart. Here we have an outlet defect. You see that it is opening between the limbs of the septal band. But as I will also show you, we can find several types of outlet defect in the setting of transposition. So not only do we need to know its geography, its opening to the ventricular outlet, more importantly, we need to know its phenotype. And here we see that in the roof of the defect, there is fibrous continuity between the leaflets of the aortic and pulmonary valves. And that is making the defect juxta-arterial. But then when you look posterior-inferiorly, you see that the defect extends to an area of fibrous continuity between the leaflets of the tricuspid and mitral valves. So here, the phenotypic feature is that the defect is both juxta-arterial and perimembranous, and it is the latter fact that tells you that the conduction axis will be at risk posterior-inferiorly. Now here is the other feature we must always take note of in the setting of transposition, and that is malalignment of the outlet septum. You see that again we're dealing with an outlet defect. There it is, opening between the limbs of the septal band, but the outlet septum, as this heart, is deviated rightwards, and that introduces a degree of override of the pulmonary trunk. And in fact, we then know that there is a spectrum of override, and as more and more of the pulmonary trunk comes into the right ventricle, we end up with double outlet right ventricle. And this spectrum is known as the Taussig-Bing malformation. But there's also variation in the phenotype of the interventricular communication. So here you see there is a muscle bar posterior inferiorly made by fusion between the caudal limb, the septal band, and the inner heart curvature, the ventricular infundibular fold. And when present, that muscular rim will protect the atrioventricular conduction axis. But here is a very similar heart, defect opening to the outlet of the right ventricle between the limbs of the septomarginal trabeculation or septal band, with rightward malalignment of the muscular outlet septum, but this time with an extensive area of fibrous continuity between the leaflets of the tricuspid and mitral valves. So now we have a malalignment defect that is also perimembranous, opening to the outlet of the right ventricle. The key feature, the conduction axis will now be at risk at the posterior inferior quadrant of this particular defect. So the other feature, the major feature we take into account when we're looking at complexity in the setting of transposition is obstruction of the left ventricular outflow tract. And here we know that anything that in the normal heart produces subaortic obstruction in the setting of transposition, because of the discordant ventricular arterial connections, will produce subpulmonary obstruction. So we can find obstruction at the level of the pulmonary valve, but perhaps most importantly is when we have caudal deviation of the outlet septum narrowing the subpulmonary outflow tract. We can also have bulging of the ventricular septum with or without a ventricular septal defect, made worse by a fibrous shelf. On occasion, we find tissue tags ballooning into the outflow tract, and rarely there can be anomalous attachment of the tension apparatus of the mitral valve. But here is the perhaps most important feature, posterocaudal deviation of the muscular outlet septum. Because in this setting now, the aortic valve is overriding the crest of the muscular septum. And there again, we have a malalignment ventricular septal defect. And it is the caudal deviation, the muscular outlet septum now, that is producing subpulmonary obstruction. In the past, this lesion was usually repaired with the Rastelli approach. Then we had the Rev approach. Nowadays, many people would repair this using the Nikaido procedure, or even by complete rotation of the arterial roots. So there are many ways now in which we can cope with posterocaudal deviation of the muscular outlet septum in the setting of transposition. Now here I'm showing you a heart with an intact ventricular septum. There is the pulmonary valve rising above the left ventricle. And the substrate here for obstruction is the formation of a fibrous shelf. And as when we see the fibrous shelf in the setting of concordant ventricular arterial connections, the shelf extends onto what here is the pulmonary leaflet of the mitral valve. The surgeon, of course, can remove this shelf with careful dissection, the problem being that it overlies the left bundle branch and oftentimes will come back because we do believe that it exists because of abnormal hemodynamics and is a flow-related problem. Here is perhaps the cutest type of subpulmonary obstruction, and this is when we see the tissue tag in the setting of a ventricular septal defect. You see those tendinous cords that are attaching the tissue tag to the tricuspid valve in the morphologically right ventricle, but the increased pressure in the right ventricle has blown the tissue tag into the subpulmonary outflow tract. And there it is, producing subpulmonary obstruction. And on occasion, surgeons have unpicked the tissue tag and have used the fibrous tissue to close the ventricular septal defect. But let's finish by looking at the other feature that is now of great significance, since nowadays, almost always, patients who have transposition are repaired using the arterial switch procedure. So knowledge of the anatomy of the coronary arteries is now of paramount importance. And we need to take account of several features. Perhaps most importantly, which sinuses of the aortic root from which the coronary arteries take their origin, but also of importance, the course of the coronary arteries relative to the arterial pedicles, and the big bugbear, is there an intramural course of one of those coronary arteries? We should not forget the importance, the artery to the sinus node, and increasingly now attention is being paid to this feature of commissural mismatch. So what about the sinusal origin? Well, almost without exception, in the setting of transposition, the coronary arteries arise from one or other, usually both, sinuses of the aortic root that are adjacent to the pulmonary trunk. It is as rare as hen's teeth to find a coronary artery arising from the non-adjacent sinus, but I do believe now there have been haphazard cases described with origin of one coronary artery from a non-adjacent sinus. But to all intents and purposes, we can think that coronary arteries are going to arise from one or other of those sinuses of the aorta that are adjacent to the pulmonary trunk. So in order to cater the variations we find, we need to distinguish between the sinuses of the aortic root that are adjacent to the pulmonary trunk. And we can do this by considering ourselves as a little surgical mannequin. We are standing in the non-adjacent sinus and we are looking towards the pulmonary trunk. Now here I'm illustrating the situation as we find it in the normal heart. So as you see, the arterial root giving rise to the coronary arteries is posterior and right-sided. And then as far as the surgeon is concerned, one of those sinuses will be to his or her right hand. And in the normal situation, we have no problem because that right-handed sinus, which nowadays we call sinus number 1, gives rise to the right coronary artery. So in the normal heart, the sinus that is to the left hand, which we now designate as sinus number 2, gives rise to the left coronary artery, and that in turn branches into the anterior interventricular and circumflex arteries. Now, when we look at transposition, as we have discussed, in most instances, the aortic root is anterior and right-sided. And that gives a potential problem to some, because now the sinus that is to our right hand, number 1, in most instances gives rise to the main stem of the left coronary artery. And that then branches into the circumflex and anterior interventricular arteries. And many people get confused by the fact that our right-handed sinus is giving rise to the left coronary artery. But all we are trying to do is to distinguish between these two sinuses. So the sinus that is to our left hand, which we designate as number 2, in the commonest situation is giving rise to the right coronary artery. Now, I still like to think of these sinuses as being left-hand sinus, right-hand sinus, because as yet I haven't forgotten which are my right hand and my left hand. And on occasion, I have problems in remembering which is to be number 1 and as to which is to become number 2. But that doesn't really matter either. All we are trying to do is to distinguish between the sinuses and to take out the influence of rotation of the arterial trunks. Because irrespective of how the aorta is related to the pulmonary trunk, always sinus number 1 will be to the right hand, sinus number 2 will be to the left hand. So if we describe the origin of the 3 major arteries from one or other, usually both of those sinuses, we cater for all eventualities. And in the majority of cases, as you see here, sinus number 1 is giving rise to the main stem of the left coronary artery, which then branches into the circumflex and anterior interventricular arteries, with sinus number 2 giving rise to the right coronary artery. The commonest variation is when from sinus number 2, not only do we have origin of the right coronary artery, but we also have origin of the circumflex artery, and significantly, circumflex artery takes a retropulmonary course. And this is why it is also important to take note of the course of the arteries themselves relative to the arterial pedicles. And so in this instance, usually the anterior interventricular artery will arise from sinus number 1. On occasion, however, all the coronary arteries may arise from the same sinus. And in this instance, where I'm illustrating the situation that they are arising from sinus number 1 with a main stem continuing down as the anterior interventricular artery, key point here, the right coronary artery takes an antero-aortic course, whereas the circumflex artery takes a antero-pulmonary course. So again, we need to combine knowledge of sinusal origin with course relative to the arterial pedicles. But this is the one that is of particular importance. When we just look at the coronary arteries themselves, it looks like we have a regular pattern, and that the main stem of the left coronary artery will be arising from sinus number 1. But in fact, it continues beyond the commissure and arises from sinus number 2 and passes between the arterial trunks, taking what we call the intramural course, before, in this instance, branching to the circumflex and anterior interventricular arteries. And so again, we have all coronary arteries arising from the same sinus, in this instance, sinus number 2, with an intramural arrangement. And there are, of course, various intramural arrangements. So what we need to do is to describe the sinusal origin of the coronary arteries as a starting point. And this is now nicely done by using the so-called Leiden convention, where we say whether the coronary arteries arise from sinus number 1 or sinus number 2. And so here you see the commonest pattern, and we took 100 hearts from Pittsburgh a long time ago, and we analyzed the coronary arterial patterns. And here you see that of those 100 hearts, 66 of them had what we can think of as the regular pattern. Now, I was in discussion yesterday with my good friend and colleague Nigel Drury, who is analyzing the extensive experience of coronary arterial surgery for transposition from Birmingham Children's Hospital. And Nigel has now done an immense meta-analysis, and he's collected together nearly 20,000 examples of description of the coronary arteries in the setting of transposition. And surprisingly, or perhaps not surprisingly, in his experience, it's again about 2/3 of the cases that have this usual pattern. In Pittsburgh, second commonest pattern in 16 cases was again the origin of the retropulmonary circumflex artery from sinus number 2. And Nigel found this in 18% of the overall described series. And in Pittsburgh, we then found all of these remaining patterns. And if you think of the potential patterns, when we have 3 coronary arteries, 2 arterial sinuses, presuming that the coronary arteries arising from the adjacent sinuses, there are only 8 possible patterns. And as you see, we found 7 of the 8 in the Pittsburgh archive. For a while, we thought that the pattern we did not find was an anatomic impossibility, but now I have been involved with a group from Łódź in Poland who found the anatomical impossibility in one of their cases, so now it's no longer an anatomic impossibility, and Nigel now tells me that there are another 7 cases of this alleged impossible pattern found in the overall description of coronary arteries in the setting of transposition. So if we take note of sinusal origin, we then bolster that with knowledge of the course relative to the arterial pedicle, taking particular note of transmural variants, intramural variants, we can produce a very nice account of the variations in coronary arteries in transposition. And here is that other feature that relates to the coronary arteries, and this is commissural mismatch. Now, usually the commissures between the adjacent leaflets of the two arterial trunks face each other. But when you look down from above, in this particular case, there is the pulmonary trunk, and you see that there is now mismatch between the commissure of the adjacent leaflets of the pulmonary trunk and the commissure of the adjacent leaflets of the aorta. And that has lengthened the distance here between the right coronary artery and the sinus into which it is to be transposed if the surgeon were to undertake a switch procedure. That doesn't seem to make a great deal of distance, but I suppose if there was extreme commissural mismatch, it could make the procedure that much harder. So it's another of these features with which now we should be taking note. So what I hope I've convinced you during our discussions this afternoon is that the essence of transposition is discordant ventricular arterial connections. And in the commonest variant, which again I believe should be the default for the name transposition, is the combination with concordant atrioventricular connections such that the blood streams are going in parallel rather than in series. And then remember the associated malformations, because they can disturb the hemodynamic pattern and they can make what might be called simple transposition into a much more complex lesion. And then these other features that in the past created so much trouble in definition description, nowadays, if we describe them, we remove disagreements regarding nomenclature. Aortic relationship can vary, but I remind you again, we should not use detransposition as though synonymous with transposition. Aortic relationships are important, take note of them. Infundibular morphology can vary. It does not change the way the blood goes through the heart. So the take-home message, transposition is no more and no less, in its regular form, combination between concordant atrioventricular connections and discordant ventricular arterial connections.
Thank you, Dr. Anderson. It was amazing as usual, and we could understand very well. Let's see if we have questions from on the chat box. We don't have, but I think someone, David, raised his hands. David, do you want to make a question to Dr. Anderson? Just unmute your phone, please, your microphone, please. No, I think he doesn't.
They're all too shy. They shouldn't be shy to ask questions.
Yes, the presentation was amazing. All we can see on the chat box is that everybody found this presentation very nice.
Well, I'm glad everybody enjoyed it. Is Norman with us? Does Norman want to say anything? Is he watching?
Let's see. Let me check. No, he's not here today.
Not here today. He's taking a holiday.
Maybe, yeah. Jean Lam, do you want to make a question? Hi. He unmuted his phone, his microphone, but we can't hear him. In this meanwhile, I have one question, Dr. Anderson. When we perform atrioseptectomy, Haskin procedure, where exactly do we torn? It's not on the fossa ovalis, right?
Well, it is when you do atrial septostomy, what you are doing is you are transrupting the floor of the oval fossa, which is the primary atrial septum. So in one of the pictures I showed, the one that had the muscular inlet defect, there was also an obvious defect at the oval fossa. And in that instance, the balloon had been pulled through and had totally disrupted the floor of the oval fossa. So that is the essence of a good atrial septostomy. You are disrupting the floor of the oval fossa.
Okay, thank you.
And as Bill Rashkin used to say, and I discussed this with him on occasion, he said the success of atrial septostomy depends on the jerk on the end of the catheter. And as you know, it is the pediatric cardiologist who is the jerk on the end of the catheter.
We can't be very delicate, this is for sure. Dr. Anderson, Ibrahim is asking, is the subpulmonary muscular septum a part of the crista supraventricularis?
The crista supraventricularis in transposition is, if you have intact ventricular septum, then the crista supraventricularis is in fact the subaortic infundibulum. It's the posterior part of the aortic infundibulum that is adjacent to the pulmonary trunk. So that is not, as in the normal heart, the supraventricular crest is not a septal structure. It is the inner heart curvature combined with the infundibulum. In the normal heart, the subpulmonary infundibulum. In the setting of transposition, the subaortic infundibulum. When you have a ventricular septal defect, however, the building blocks of the outflow tract come apart. So then typically you see the outlet septum as a separate entity, and that is the typical feature of the ventricular septal defect, as I tried to show you. And that outlet septum coming apart can either be deviated anterocephalad, and then it can obstruct the subaortic outlet, or as I also showed you, it can be deviated posterocaudally, and then it obstructs the subpulmonary outlet. So the definition depends whether or not the ventricular septum is intact. If it is intact, then the supraventricular crest is no more than the subaortic infundibulum, whereas in the setting of a ventricular septal defect, then the building blocks, as I say, come apart. And you can see then the inner heart curvature of the ventricular infundibular fold separate from the muscular outlet septum.
Okay, thank you. We have a question that we talked about it in our previous development of the ventricles session, but I think it's worth repeating that. Pranav is asking, which is the most reliable feature of right ventricle? Coarse trabeculations, moderator band, tricuspid valve with intact ventricular septum.
Well, if you have intact ventricular septum, then you can use all of those features. And so it depends upon the circumstances. To me, as a morphologist, I think the most reliable feature in all situations are the coarse apical trabeculations. But that is because as a morphologist, I can compare the trabeculations in the one ventricle with the trabeculations in the other ventricle. And as you all know, that in the clinical situation, that's not always feasible. So you take into account whatever information you have at your fingertips. And I think that probably then it depends whether each ventricle has its own inlet. If each ventricle has its own inlet, then almost certainly the most reliable feature is the presence of tendinous cords attached to the septum when it's in the morphologically right ventricle. The lack of tendinous cords from the mitral valve attaching to the septum in the morphologically left ventricle. I guess for echocardiographers, when each ventricle has its own, is tripartite, then the moderator band is particularly important because you never find a moderator band in the morphologically left ventricle. But the bottom line is you use whatever you have at your disposal. If we think of functionally univentricular hearts, probably the best guide is the relationships between the incomplete ventricle and the complete and the dominant ventricle, because I have never seen a heart in which the left ventricle is dominant when the incomplete ventricle has been posterior-inferior, just as when the right ventricle is dominant. I've never seen the situation except when the incomplete left ventricle is inferior, either rightward or leftward. So it depends upon the circumstances, but you take all of these features into account? It's a good question.
Oh, sorry, we have a big question from the YouTube. They ask if you can come back a bit about LVOT obstruction in transposition.
Well, what I tried to say is that anything that in the normal heart produces subaortic obstruction, in the heart with discordant ventricular arterial connections of necessity will produce subpulmonary obstruction. So this is going to be the case whether we have transposition in its commonest feature, which I've discussed today. The same lesions can produce subpulmonary obstruction subpulmonary obstruction in the setting of congenitally corrected transposition. So probably the most important is the caudal deviation of the outlet septum. But if the ventricular septum is intact, then almost certainly the most important is septal bulge combined with a fibrous shelf. And that oftentimes that fibrous shelf is called a membrane. I think that is a mistake. It is not membranous. It's much more than a membrane. It's a thick fibrous shelf. It sits on the septal surface of the ventricle. Sasha, you will know this. You can liberate that shelf as a surgical procedure. You have to be careful in regular transposition because the shelf will be lying across the left bundle branch. And the other problem, of course, you take it away and oftentimes it comes back. And that's because it's flow dependent. But that is the commonest type of outflow obstruction when you have an intact ventricular septum. But don't forget those other lesions. I showed you that cute, what I call that cute little lesion, the tissue tag. We see that also in congenitally corrected transposition. And of course, don't forget valvar obstruction, because valvar obstruction can coexist with any of these other lesions.
So another one, Fanulamed is asking, there is a typical coronary pattern for when it's associated with the right ventricular obstruction. It means there is you can say if there is an obstruction, there is a type of coronary pattern?
Not in my experience. I think that there is no association between the associated malformations. I think if you have transposition, you must anticipate any of those patterns. And I was amazed, as I discussed during my presentation recently, to find that the so-called impossible pattern can occur. But I think if you do what I suggested, you describe the sinusal origin, you distinguish between the sinuses, and then you take into account the course relative to the arterial pedicles, particularly taking note of the intramural variants. You can give, because you as Sasha, you want them to tell you what you are going to anticipate finding in the operating room, do you not? And you particularly want them to tell you if there is an intramural variant. Now, I mentioned the meta-analysis that Nigel Drury has been doing, and it used to be, and you will know this, Sasha, also, it used to be that the intramural variant was a potential risk factor. The interesting thing, and Nigel's meta-analysis now shows this, that that is now being mitigated. You as surgeons now know how to deal with intramural patterns, but correct me if I'm wrong, you would like to know in advance whether there is an intramural pattern.
Yes.
Okay, we have a couple of questions. Jose, let's say, a son is asking about the imbiologic theory behind the appearance of transposition.
Well, that is another bone of contention. But I think we now know with reasonable accuracy that the reason you get transposition is that the outflow cushions, which usually fuse together in spiraling fashion, when the embryo is going to develop transposition, those cushions fuse in straight fashion. And it is the straight fusion cushions that then puts the right ventricular outflow tract in communication with the systemic pharyngeal arches and the left ventricular outflow tract in communication with the pulmonary arch. And we now have strong evidence that that is the case. And if we then combine the knowledge that the cushions can fuse in straight fashion within the proximal intermediate parts of the outflow tract, the way that they then fuse with the aortopulmonary septum, which grows into the outflow tract from the aortic sac, that can give us an explanation for all forms of abnormal ventricular arterial connections. And that's something that we'll get round to and we'll discuss in one of our future classrooms, this problematic lesion that's often called anatomically corrected malposition, which I think that's a terrible term, but we'll get onto that. But we can explain all of these lesions now according to the way that the cushions in the outflow tract fuse with the aortopulmonary septum.
In the same subject, Alvisi is saying that I was under the impression that DTJ and LTJ was more referring about the looping than the alignment of the great vessels. If you could please clarify.
Well, that many people say that, but I showed an example of transposition existing in the setting of mirror image arrangement. And if you have mirror image arrangement, you have transposition ILL. So that is leftward looping. And if you have transposition ILL, then whether you're going to take the position of the aorta into account or whether you're going to take the loop into account, you have an L loop, you have an L aorta, but it is still regular transposition. It is not congenitally corrected. However you go about it, you cannot use detransposition as a synonym of what we are discussing today, and you cannot use L transposition as the same thing as congenitally corrected transposition. So for example, if you have transposition IDD, which is congenitally corrected, it is D transposition. And the people who use L and D transposition in this fashion are not using Van Praaghian terminology as it should be used. As always, Dr. Van Praagh would talk about transposition SDD, transposition SDL, transposition ILL, and you need all of the segments. You have to put them together, and only in that way can you combine and give a correct account. D transposition is not the same thing as the lesion we have been discussing today.
Amazing, thank you.
Can I tell you that, Grace, the people must be so happy. We passed one life to receive this 5 minutes explication.
Explanation, exactly.
I am very impressed, though. Thank you very much. I'm not joking. It's amazing opportunity. So very happy. So I think we can stop here. What do you think, Grace?
And correct me.
We had some.
Sasha, correct me. I think next week we are having a holiday, are we not?
Yes, yes. And then we will see the week after. Yes.
So everybody has a holiday for next week. So in 2 weeks' time, and we're going to do double outlet right ventricle, are we not?
Yes.
Is that right?
Yes. Today
so
we
that's
have
something to look forward to as well. We can have lots of discussions about double outlet right ventricle.
Yes. Today we have people from Mexico, Russia, Peru, Armenia, Indonesia, Malaysia, Pakistan. It's amazing.
It is indeed. And I'm glad that everybody enjoyed the presentation. It was great for Sasha and I to put it together. And Grace, thanks to you for organizing it. Did I see when we at one point, you have a cat there that came behind you?
Yes.
So you have a cat with you in Qatar.
Yes.
She really likes to participate as well.
So we will see in 2 weeks. We thanks everybody and hoping we receive your feedback for this unique presentation from Professor Anderson. And thanks again to everybody.
Cheers to everybody.
Bye. Bye, Grace.